So people don't want to go.
Springtime again.
They pay 10.
Good afternoon and welcome to the Board of Health meeting, October 7th, 2024. Please note this meeting is being recorded and will be available shortly hereafter for scheduled and on-demand viewing on any smartphone or tablet. If anyone else is recording this meeting, please notify the chairman. Pursuant to Governor Healy's March 29th, 2023 signing of the Acts of 2023, extending certain COVID-19 measures adopted during the state of emergency, suspending certain provisions of the open meeting law until March 31st, 2025, this meeting of the Chatham Board of Health is being conducted in person and via remote participation. Every effort will be made to ensure that the public can adequately access the proceedings as provided for in the order. A reminder that persons who would like to listen to this meeting while in progress may do so by calling the phone number 1-508-945-4410, conference ID 467-154-994 #, or join the meeting online via our Microsoft Teams link in the posted agenda. While this is a live broadcast and simulcast on Chatham TV, Channel 8 and 1072, despite our best efforts, we may not be able to provide real-time access. We will post a record of this meeting on the town's website as soon as possible. And now I'll turn the meeting over to our chairman, Dr. Noble Hanson.
Thank you. It shall be the policy of this board to conduct its meetings under the open meetings law so as to encourage public participation whenever time permits and as part of agenda item discussions. We have three things on our agenda today, but first let's establish a quorum, and when I call your name, please say present. Carol Boyce.
Present.
Dick Edwards.
Present.
Ron Broman.
Yeah.
And myself, Noble Hanson, I'm here. So we've established a quorum. We have, there were three things on the agenda: Narcan training education with Alicia Morrison. She unfortunately had a last-minute emergency and had to cancel, so she won't be here today. Judy will try to fill us in on some of the Narcan training information. And then a discussion with Stephanie Briotti, co-founder and CEO of Behavioral Health Innovations, BHI. And then a discussion with Michael Lopriore, Chatham EMS fire captain. And I will, Judy has kind of put this together, so I will turn it over to her and she can tell us what we have in front of us.
Hi. So it's unfortunate that we can't have the Narcan training and education, but as you know, we have put a few Narcan or naloxone boxes up around town, and they're stocked by the AIDS support group of Cape Cod. Right now, they're in town buildings at the Fish Pier, at the community center, and here at the annex. And we've done some trainings with town personnel so that they know what it's all about and how to use it if anything occurred and they needed it. We've also supplied those buildings with extra Narcan that they can restock them should someone take some, which is perfectly acceptable because it's there for the public to use. And we're trying to destigmatize the issues around substance use addictions. So I can't do the training, so I won't go into that, but.
So,
yeah.
Just one question. So these are open to the public and anyone can come in and take the Narcan and take it home to use themselves?
Or to have it, should they be
whatever.
concerned, or they're in a workplace, or they have a family member and they're concerned and they want to keep it, it's perfectly
And
fine.
is there a list of where the boxes are?
Right now, there's three in town. We use some public health excellent, our regional work group, health agents work group, money to purchase the three, and I'm hoping to get a couple more and put them in a couple other locations in town. So they're at the Fish Pier, they're at the community center, and one here outside this meeting room at the annex.
So they're outside where the public can access them, or?
The one at the Fish Pier is outside. The one at the community center is at the desk. So they would only be accessible while the building is open. Mm-hmm. The same here. So, yeah, Ron?
Judy, I'd like to thank you for doing this, really. You know, if it saves one person in Chatham here, it's well worth it, really. I mean, being a teacher in class during the drug culture time, I used to see some kids in pretty rough shape, and there was never anything like that to help them. You know, we just had to get an ambulance, come over and do whatever.
Right.
but. I
Well,
think
we're
this is
trying
great.
to, we're trying, as I said, to, make people understand the situation and destigmatize the whole issue around substance use. And there's opioid funding from pharmaceutical companies that the town has received and will be receiving over $300,000 over the next 15 years. So we're using that for this type of work and making an effort to, bring you guys up to date and the town as well. So I'm hoping that we can do this training again. We did do one for the town and we recorded it. I'm not sure if Channel 18 has been playing it or not, or it's not Channel 18 anymore, but Chatham TV. So hopefully if they've been playing it, it's a good training, there's a lot of good information, so. So we'll provide that again, hopefully soon. So do you want to move on to the next?
Yeah, go ahead, BHI.
So I just want to introduce Stephanie Briotti, is co-founder and CEO of Behavioral Health Innovations. She's got programming in the Monomoy schools and schools around Cape Cod. And I thought that this would be a good topic. I know that you've had some interest in knowing what's going on in our schools on this topic of substance use. And she has also received some of our opioid funding in grants in the past two fiscal years, so.
Are we done with Narcan?
For now,
Well, I just wanted to make the point that throughout my career, I had patients who were using drugs and Narcan was useful. But the great majority of those patients were taking heroin, injectable or snorted, and that was the way people were getting these overdoses of narcotics. But today, the latest problem is the drug cartels are making counterfeit pain pills, oxycodone, Percocet, OxyContin, and they're lacing them with fentanyl.
Yep.
Because fentanyl's pretty cheap to make, and that's extraordinarily dangerous because that can be extremely potent. So you can just take what you think is a Percocet and end up with a major overdose and need Narcan. So it's not just people that are using
right.
heavy drugs, not heroin, injectable drugs, but if you get addicted to an oral pain pill because you were getting them out of your mother's medicine chest and ran out, and you go out on the street and buy some quote Percocet, that it looks like Percocet, but it may well be
It's very scary.
a drug that comes from one of these drug cartels that's manufactured and contains fentanyl. And a little bit of fentanyl can be extraordinary. Even like firemen and policemen and things have to be extraordinarily careful because just a tiny little bit of fentanyl can create a huge overdose problem.
So that's, I think, one of the problems that has been creating this issue over the last, 10 years. Hopefully, we're going to start getting a handle on this soon.
Yeah, so I'll just say, next month, Judy will give the community health survey results. And then shortly after that, we'll have a community health services forum because a lot of community health problems morph into community services. And we'll try and get this Narcan training education person back and talk at that session so we don't miss out on it, I think.
Right. And to that extent, Stephanie is kind of under that umbrella as well as someone providing valuable services in our community. So we all set to it.
Sure, absolutely, yeah. Go ahead. Sorry.
It's nice to meet you all. I'm
Thank you for
Stephanie
coming.
Briety, the co-founder and CEO of Behavioral Health Innovators. And our mission is to create a continuum of supports, especially for young people and youth who are struggling with substance use and mental health challenges, with the aim toward ensuring that they have a full and productive life. And I'll start just with some background. Even though you've probably read in the latest news that the overdose numbers have gone down a little bit nationally, Obviously, there's still a crisis. So the DPH commissioner said it's hard to find hope in the numbers. In 2023, there were 112,000 in a 12-month period. That's overdose deaths. And to your point, I forget your name, but to your point, it is from the fentanyl. The fentanyl's being cut into all of the drugs because it is cheaper. So it's being cut into cocaine, and it's being cut into some of the drugs that, you know, are out there that people have been used to using, and now they're no longer safe. So what he says, too, is though the deaths are leveling off, we're leveling off at the highest numbers. So it's still a very jarring number to have to report every 6 months. So it's over 2,000 this year in Massachusetts. And focusing on the youth, because that's really what we're trying to do, get upstream of the addiction problem before they need the Narcan to get them when they are first starting. We have to look at, like, zoom out and look at the environment that we're all living in. So today's youth grow up in an environment that's saturated with the recreational use of cannabis. And Massachusetts is making a lot of money in tax sales and gross sales for cannabis, but it's still something that if you're looking from a seventh grader's perspective, you see many people buying cannabis, lots of information about it. Even on the front page of the Cape Cod Times not long ago, excuse me, was a gummy bear, a cannabis gummy bear laced with THC, and it looked just like a regular gummy bear. So they're very, as you all know, you can think back to when you were young or your children or grandchildren, they're like sponges and they take everything in. So youth substance use treatment, there's very few adolescents with substance use problems that receive treatment. I said 8.7% age 12 to 17 have a substance use issue in the past year. That was 2022 data. Only 0.5% sought treatment. 2% did not seek treatment, and 97% do not seek treatment or think they should get it. So there's very little treatment for psychological problems that are connected to their substance use. This is from the from NIDA, the National Institute for Drug Addiction Services. Unintentional drug overdose death rates among U.S. youth aged 15 to 19. It's boys, and it's the highest, and it's rising. So that's more, more proof really for us that we need to get into the schools and we need to get to the kids a lot sooner rather than trying to play catch up when they're in their 20s or 30s. And now we have the simultaneous use, so this is young adults, simultaneous use of alcohol and marijuana. It's now linked to more drinking and more negative alcohol consequences and more hours being high. So these statistics, they say they're specifically related to the simultaneous use of both alcohol and marijuana rather than simply the amounts consumed. So there's this synergistic effect between both of them, and that's also what we're seeing happening in the schools. So one of the programs that the town of Chatham, through its opioid remediation fund, is supporting in part is our PASS program. So this started as a positive alternative to school suspension. That's what PASS stands for. And it's now called the Positive Alternatives for Student Support. So it's open to students facing suspension, but also to students not yet facing suspension who need some support outside of school. This is just some of the curriculum from the PASS program, and I'll walk you through kind of a day in the life of PASS. So say you're David Alexander, who's the assistant principal over at Monomoy Regional High School, and you have a student either that was caught vaping in the bathroom or is having a lot of anxiety. Something happened at home and they can't focus. So he'll call up and ask if that student could attend PASS, which is being held for high schoolers at the Centerville Rec Building in Barnstable. And we supply David with DART bus passes, so the student has transportation from home to PASS and then back to school. So typically PASS is 5 days. It's from 9 to 2. It's during the school day. Students have their Google Classroom laptops. All of their homework and schoolwork is done in real time. And we partner with Outer Cape Health Services to provide a clinical assessment for anxiety, depression, substance use, trauma, and suicidality. So part of the experience at PASS, you arrive, typically it's the academics that get focused on first, but we also have all of the social emotional kind of supports that the students need, and there's a program director that runs these psychoeducational groups with the clinician from Outer Cape Health Services, and the students start setting their goals. One, I think it says get good grades, basic kind of supports. So the approval for the program is really universal from the students to the parents. The students, what we've seen, the golden kind of nugget in all of it is they are much more ready to self-identify as having mental health or substance use issues. And they don't say it like that, but they're going to unbottle their anxieties and their struggles much more readily outside of the school setting, which isn't to say there's anything wrong with the schools. It's just that it's like going to fresh air camp. They get out of the school environment, they're with kids from other schools, and there's an opportunity to talk with people that seem like they're not school personnel, and really care to hear what's going on with them. So some of the metrics. To date, 232 students have attended the high school PASS program since we launched in May 2022. 65% of that 232 presented with a substance use challenge, 80% presented with mental health challenges, and 56% presented with both. And then the metric that for me is the one that tugs at my heartstrings the most is, so these are high school students. Only 33% of those students were receiving services before they came to PASS. So they were being suspended or they were white knuckling it for all these years without any services. So over the next 2 years, we're going to grow the capacity of PASS to serve more students. 16 schools now send students to the high school and middle school PASS programs. We opened the middle school PASS program on October 1st this year. We expect to have about 75 students.
Can you say, how do the students come into this program? How do these students come into the program? Do they self-refer? Are they all identified by the principal, the administration, or?
Good question. So thank you for that. The ones that are facing a suspension, the school is required to have a meeting, and at that meeting, they offer them either their suspension. So for vaping, for any substance use, it's usually 10 days out of school. And they offer PASS, which is 5 days. So there's a little carrot in that for them, so that they can, be gently nudged to take that option. It also doesn't count as a suspension on their record, and the school does not have to report it to DESE, the Department of Elementary and Secondary Education, as a suspension.
Do patients, do kids self-refer? Does it all come from the school administration?
It all comes through the schools. The schools are equal partners in the program. So it's the adjustment counselors, the assistant principals. Parents that have heard about the program have to go through their school district to come to program. And of those 16 schools that send, now Wareham, which is in Plymouth County, Nantucket, which is in Nantucket County, are sending kids to this program in Centerville, because there's no program for them where they are. In addition to the PASS program, we started another program in 2018, so about 4 years before we launched PASS, called the Alternative Peer Group Program. And this is for young people aged 13 to 17 with a history of substance use. It's free. We partner with Duffy Health Center in terms of the clinical aspect of that program. They oversee the licensed clinician. There's a youth behavioral health specialist, a recovery coach, peer mentor, and a supervisor. This program that we started, BHI started in 2018 just on our own, just doing our own fundraising, is now funded in part by the Division of Youth Services up in Massachusetts. So it's a state grant, a BSAS grant, Bureau of Substance Use and Addiction Services grant, that partially funds the APG program. The reason we're bringing this slide up now is, remember, go back to the past metrics. The 65% of students are identified at PASS that have substance use problems. They can be plugged right into this program. So again, the mission of BHI is to create that continuum of supports, so these kids aren't just identified and dropped. They're identified and referred over to the APG program for a 6-month program. And in that program, I should say the metrics there, and I don't have them up, 88% of the students that attend that program achieve their recovery goals. And then 6 months out of that program, after completing the program, 44% still identify as being in recovery. So again, this is the continuum of supports. We've talked about a lot of it, but the idea is not to supplant what's happening in schools, but to augment what's happening in schools. And particularly Monomoy High School has been an integral partner in not only implementing the program, but also in creating the program. The schools that are sending middle school students now, and this is 5th, 6th, and 7th, because most high schools on the Cape have 8th grade part of their high school. So the 5th, 6th, and 7th graders are coming from DY, Falmouth, Barnstable, Monomoy, and Nauset. And we anticipate that program's going to grow. And it was really the administrators of the school that said, this is great that you've got this for high school kids, but we know the students that need support when they're in middle school. So can you have a program like this for the middle schoolers?
School administrators point out the kids. All right. School administrators point out the kids that should be in this program to you, or guide the kids in your direction?
To our program director, yes. It's a Google form they fill out, a referral form for any student. They give us 24
So they don't have to be in trouble, that they can just be,
They could just need the
sense that they need help.
Exactly, that they need the program. And a lot of times it's kids that the school has been trying, over and over and over again to support. And it's just getting them out of the school environment, really, and back into an environment where they're more comfortable to share. Yes?
Do you also include marijuana in this program? Do you all?
Absolutely.
You do include it in, because it's so much changed now over the years, it's.
Yeah, any of those substances for schools in their school policy books, it's all suspension kind of warranted. But, we don't really deal with the marijuana use. We're basically the ones that say, you're in trouble, how can we help you? Not you're in trouble, how can we punish you? So the whole point of PASS, and it was the brainchild of a woman up in the North Shore who started PASS back in 2018, Michelle Lipinski, who's the principal of the Recovery High School up there. She's the one that said it's not only does suspension not work for this population, and again, you saw the numbers of the things these kids are facing, it's harmful. It actually harms them. So it's to get, really address that issue, which is a whole juvenile justice kind of issue, but then it's also to open our arms up. And it was Jen Police, the principal at Monomoy, that said, why do I have to wait until they're going to be suspended? I know these kids need help. So we get them sooner. before the infraction.
Are there areas that you serve that have more of a problem than others? Are there certain,
The majority of students are coming from Barnstable High School, and that's not to say they have more issues. The youth behavioral health survey that the schools do in Monomoy releases, Monomoy's numbers for vaping, marijuana, all of that exceed the state limits. So they're all having the same kind of problems. Are there any more questions about either program? And you can go to our website and look at more. I do want to make a plug, though, for we're having an event at DY High School. It's Thursday evening, 6:30 p.m. this week, October 10th, and it's called Real Talk, and it's about youth mental health challenges. And we've partnered with an organization called the Quell Foundation, and they have a documentary, and it's Portraits of Life with Mental Illness. And it's from the youth and young adult perspective, and it's free of charge, and we invite everyone to come watch this documentary. And I'll end with saying we had 3 counselors in Chatham and Harwich to review the film before we decided to show it. And they said, not only should everyone see the film, everyone needs to see the film. Thank you very much.
thank you. Now, do you interact with this recovery coach position that's new, I guess?
The recovery coach here,
Yeah.
I know the clinician that you hired here, Diane Nash, and she's told me about the recovery coach. Is that
Right.
Kelly?
Yes.
Yes, I haven't met her, but I've heard great things about her.
Right. So Diane Nash is our full-time adult behavioral health clinician. And then we have a recovery coach being supported by the opioid remediation funds, who is here one day a week, Kelly Conley, and she comes to us through Outer Cape Health Services. And they work very closely together. And with other staff in town, including our next speaker. We meet monthly, and we go over issues with folks in town, what's going on and who needs help, and we try and provide services as needed.
Okay, thank you.
All right?
Thank you.
Thank
Other
you.
questions from the board? Any questions from,
There's no one online, so,
Online? okay, all right, great, thank you very much.
thank you.
Thank you very much.
Thank you, Stephanie. That was great. Do you want to move on?
Yeah.
So our next speaker is Mike Priori. He's our Chatham EMS captain, and as I said, he works very closely with our mental health team. And you had asked, what it looked like in town, the issue, and I thought he would be helpful in providing us some of that information, so.
Great. Yeah,
Good
thank you for
afternoon.
coming.
Thanks for having me. I appreciate your time. I don't have a fancy PowerPoint presentation. I just have a little bit of data for you guys as far as the town of Chatham. What I have here is back to 2019 when we started keeping track of our Narcan administration at the fire department. I have some numbers progressing over the years to kind of show some trends. So in 2019, Narcan was administered 10 times. 2020, it was given 13 times. 2021, it was given 26 times. 2022, 17. 2023 was 8. And 2024, we are already up to 11. The year's obviously not complete, but that's the data we have so far. Obviously, some of those years are to be expected, given other trends that we had at the time. There was a downtick in 2023, but we have seen that come back up in 2024. We have also seen an increase in the dose administered of Narcan over the years, which would correlate with some of the increased potency in some of the drugs that we're seeing. Obviously, in the emergency medical services, we don't have as much data as far as blood work that they get at the hospital. We don't necessarily have access to that. What I will say is not every Narcan administration correlates directly with an overdose, and not every overdose presents with Narcan administered. So this is just the data that we have. It's not by any means all-encompassing. I think it's great that we have public access to Narcan now. I think that definitely presents some newer problems. One of the issues being Narcan's half-life is significantly shorter than most of the drugs that it's designed to treat. So what I would say is encourage people to continue to call 911 for help
Yes.
if they believe they need it, because if they are administered Narcan at home and they're not seen for further treatment, there's the possibility that Narcan can wear off, and they can re-overdose with what's in their system already. So I think as much as that is a great thing to have in town, we want to make sure we encourage people to not shy away from calling emergency services if they need help. I think that's still a resource they should utilize, and like Judy said, try and decrease the stigma around overdoses and just encourage people to get the help that they need. So, short speech, I'm keeping track of this stuff. We try and track trends as much as we can, but if you guys have any questions, I'm happy to answer them.
So you're using the nasal Narcan?
We have the ability to give it nasally, but we can also give it intravenously as well. So it depends on the situation and the nature of the call. We can give it both ways.
So you try to determine what it was that they took to determine.
So the
or just
Narcan
how-
administration for us is typically based on a very specific protocol. We're trying to treat respiratory depression. So we can give it if we believe there is an overdose, but we try and reserve it for someone who needs it in order to breathe. Sometimes as a blanket treatment, if we're not sure, if there's evidence of an overdose or suspicion of it, we will give it. Typically, that's the nasal dose. We give it first because we don't have to establish an IV first. So that's the easiest way and the quickest way for us to give it. Other times, if we have somebody who is overdosed and is still breathing, if their respiratory rate goes down further, we will administer it via IV. So it kind of depends on the provider on the call and what they believe is the most appropriate.
And do you frequently have to give a second dose?
Not frequently, no. It does happen. What I have seen is we do have a larger, more concentrated dose. So the initial dose is anywhere from 0.4 to 2 milligrams. We have a larger dose of 4 milligrams, and that has been given more frequently in the past 2 years. Typically, that's associated with more severe respiratory depression or a suspicion of a higher overdose, depending on what they find on scene.
And in Chatham, what drugs are the primary drugs that you're being called to?
So we
deal
don't
with?
typically have access to that data. We don't get to know after the fact whether the police take that stuff or whether they do blood work in the hospital. I don't have access to what they find in the blood work or what they find on scene.
They don't tell you?
No, most of the time, people are very hesitant to tell us what they took, if they took anything at all. There, I believe, is still the stigma that they're going to get in trouble, so they're less likely to report to us exactly what they took. It does happen, but it's not as common.
So you're just seeing someone who has respiratory depression
Correct.
and assuming it might be narcotic related.
we may
and
find
give it- and
paraphernalia
giving them
on scene.
Narcan because
Yeah.
it really doesn't have any significant.
Yep, yeah, the one thing we want to be
Downside
cautious
risk.
of is if we give it and it's possible to give Narcan to somebody and they could go into withdrawals if they're significantly dependent. But it really is a very benign drug for us to give that has a really positive outcome most of the time. But the indicator for us is respiratory depression. But if the crews see signs of paraphernalia or somebody calls us and says they overdosed, this is what they took, then we'll give it.
And it can't hurt the people if you give it and they're not overdosing. It's pretty benign, as you said.
Relatively so, yes. There's
Yeah.
very few risks.
Now, so do you give different initial doses? How do you determine the initial dose you might give someone?
So we have a dose range in our protocols that we can give based on clinical presentation, how severe we believe their respiratory depression is, how long they've been down for, how much we believe they've taken. Typically, there's a standard dose of 2 milligrams that we give because that's how it comes and it's easy to give quickly. But we do have the ability to titrate that based on the clinical impression of the
So it's kind of a
paramedics.
subjective judgment on your part
Yep.
based on the whole thing?
Absolutely.
All right, and then, so if you're called, is the police also called always, or?
It depends. So medical calls don't always come in the same, so it doesn't always come in as this is a narcotic overdose. It may come in as somebody's sleepy, somebody's unresponsive. The dispatch reason is different. The police oftentimes come to assist us with calls. If it is coming in as an overdose, typically they do. If it comes in as a general medical and unknown medical, they may if they have units available. So it depends on the nature of the information we're given at dispatch. We can also request them to the scene if we believe it's necessary to have them there, whether it be for the patient or for us. But it all depends on the call itself.
So you might be called and treat somebody, but you're not obligated to call the police?
Not necessarily,
No matter
no.
what you think, really?
Nope. The police do have a reporting database that they use to encourage services for people. So they have a system they enter data into for fatal and non-fatal overdoses that they can help coordinate services after the fact for people if they want them. But that's not something I have access to. That's a separate service that they do.
And then, where are most of these cases? Are they in private homes? Are they outside, or?
Mostly
school,
they're in private residences. There's no correlation to location or anything like that, but that's typically when we find people is in homes. We don't usually do a lot of digging when we get there as to whether it's a rental or a permanent residence or a temporary residence. but most of the times it is in somebody's home, yes.
And do you see repeat cases?
We do.
Place you've
It's
been
not
before?
common, but we do, yes.
And then are you obligated to refer for treatment, or is that something the police do, or how does that work?
No, so the way we work in EMS is we have a little bit of we have rules governing what kind of information we can share as far as medical records. So we can refer people for services if we have their permission to do so. We can also notify our substance abuse. We can notify Kelly, and she can reach out to them and say, hey, would you like some help? And that can also be done by social workers at the hospital once they get admitted or treated there.
Right, so that'd be something the hospital, social workers would do,
Yep.
suggest.
Yeah, we primarily focus on the patient care, getting them stable into the hospital, but we do, if we have the time or the ability to talk to them and discuss, hey, would you like to get some help? We do have some resources we can refer to them. Yes, sir.
What's the rate of response in terms of minutes with the nasal versus the IV that you give? And,
Typically, it depends, and it's hard to tell because obviously it depends on how much they've taken, how long ago they've taken it. Usually, we see effects 30 seconds to a minute, maybe even a little bit longer, 2 minutes, 3 minutes, depending, but it usually is a fairly quick effect. We can deliver manual ventilations in the meantime if we need to support their respirations until the drug takes effect. If it doesn't, we can give them another dose, but it's usually a relatively quick interaction.
So the nasal also works quickly.
Yeah, nasal is
Work
preferred
quickly.
because of the ease of administration, how quick it is for us to, typically if we go out to a call, we can have that ready to administer already before we even get there. And once we get there, we can do an assessment, and if we determine it's necessary, they can administer it pretty much right away.
And what percentage of the people that you treat with Narcan are taken to the emergency room? Or
Most of them. Typically,
60% or
I would
90?
say it's higher than that, probably closer to 80. Most of the time when we administer it, there is a lag time. So in that lag time, we typically package them, we check their vitals, we do other treatments, and we get them in the truck and ready to go. And usually once they become alert, they're already on the way to the hospital and they don't argue as much about going. Not everybody wants to go. And if they're alert and oriented, they have the right to refuse treatment and transport if they want to. So that's something that we deal with that can be difficult as well. As far as we can't kidnap people, we can't really take people against their will. So if they're able to make decisions, and we can't take them.
So if somebody is in respiratory distress, they're in danger of dying of anoxia, and you give them Narcan, and 2 minutes later they're fine, they can say, I don't want to go to the hospital.
Yeah, it's
Go-
based off
go away.
it's based off their mental capacity. If they have the mental capacity to refuse care, they can refuse care.
So then you stay around for a while to make sure it's not going to,
We can't stay if we're not invited. If they say, get out of my house, we have to get out. And again, that kind of goes back to my concern with at-home Narcan presenting some new challenges of people administering Narcan. They become responsive and they breathe and they say they're fine, and maybe their friends leave and then they re-overdose and now they're home alone.
have you had to be called back?
We haven't recently. It has happened in the past, but not in the past few years.
So if a patient is not really ventilating or, moving air, can you give nasal Narcan?
Yes, yeah, we can give intranasal drugs even if they're not breathing, and then we can breathe for them. Yep.
And then I know you don't know statistics from other towns, but do you have a sense of the relative number of cases in adjacent towns, Dennis, Harwich?
It's difficult to
Hyannis?
say. Everybody tracks it differently. Again, I'm looking specifically at the administration of Narcan, which may not directly correlate to a specific overdose. It's just how often it was administered. Busier towns, typically it's a direct correlation. The busier the town is, the more overdoses they deal with. The bigger cities, the villages always have usually a higher incidence, but that's just because they have a higher volume of calls.
Have you ever been called to one of the schools?
Not to my knowledge, no.
Right.
No.
So the nasal, it's not like an asthma inhaler. It's absorbed right through the nasal mucosa.
Right through the nasal mucosa,
They don't have
yeah.
to
So
breathe.
it's
You
an
don't actually
atomizer.
take a breath. You
Basically,
just
there's a
shoot it
little
in.
foam tip you put on there, and as you push through, it converts it to a mist, and it's absorbed directly in the mucosa. So it doesn't have to be inhaled.
In the training that we didn't have today, she does say much of what Mike has just presented, that you can give a second dose if after 2 or 3 minutes the person starts to overdose again. There were also, people are concerned about liability. There's a Good Samaritan law in Massachusetts, so you're not liable if you give it. It's not going to hurt them even if they're not overdosing, but that's always a concern, as well as doing CPR and rescue breathing. But we do stress that 911 should be called first. And that's the most important message, I think, in all of this, is to make sure that even if you're administering the Narcan, you should call 911. for backup.
So you never leave Narcan for them to self-administer, but they can come to one of the town buildings now
Yeah,
and
they
get
can
it?
come down and get it. They can get it over the counter at most of the,
Well, over the counter?
most of the
can buy it.
pharmacies are offering it over the counter now without a prescription.
Yeah.
And there is a program in Massachusetts to have people come to a fire station and get it. We haven't started it yet, but we are looking into it. As far as access to, if they wanted to come in and get Narcan, we have what's called a leave behind Narcan protocol available to us. We just have to do
Is there,
something on
is
it.
there a charge if you buy it over the counter or get it over the counter?
I don't know if citizens go get it over the counter, if they are charging for it. I'm not sure exactly how that works, so.
I think there is a fee. for
Yes,
it.
yeah.
Do you have an age range for these numbers? Do you have
You-
an age
no.
range?
You have
As
to
far as
come
the
to
question, do we have an age
microphone.
range? I do not at the moment. I know that we don't see numbers typically below 18, but it is usually between 20 and 50 is the most common age range.
Okay, great. Other questions from the board? Any questions from the?
No?
All right. And, okay, all right, great. Thank you very much.
Thank you.
Thanks, Mike.
Okay, that's all we have today. Our, Narcan training session had to be canceled. So I would just ask the board, are any old business or issues that people want to bring up?
Can I,
Yeah, Judy?
just remind folks that we do have a drive-through flu and COVID clinic, this week, October 9th from 10 to 12 at the DPW, and you can go to the town's website, to the Health Division page, and click on the flu clinic, link, and you can register right online through that. And if you have any issues, you can call the Center for Active Living or the Health Department. We would help register if you're having issues.
I was told by someone that you can just walk in without an appointment. That's not the way it's supposed to work, right? Somebody said, oh, you don't have to make an appointment, just walk in.
We prefer if you have an appointment,
Because they ask you all those questions when you register.
right.
you
I
know.
mean, if it comes to it, we can probably register people on site, but it just kind of mucks up the works. It's much easier and flows better if people register ahead of time.
And it's flu and COVID.
Flu, and we have the high-strength flu
And you give them at the same time, different,
if they want them, yep.
if they want them, yeah.
Or same arm, if they want it.
You have the choice of the regular flu or the high-strength?
Yes, I believe so, yep.
Was it age or your choice?
Age.
I think it's age. I think it's 60 and over, you get the high-strength.
Or immunocompromised?
Right, right,
But you may have more side effects.
yeah. I'm not sure about that, but yeah. So we do have the clinic on the 9th, which is 10 to 12. If people can't get to that, we do have another clinic on the 16th. Same routine, go online, register for it. That one is from 3 to 5 p.m. So same place at the DPW drive-through, 221 Crowell Road. So there's two opportunities.
Okay, anything else? And then our first meeting in November, we're going to have the Community Health Survey, Judy's survey report for us. And then probably the second meeting in November, we'll have a little forum on community services with somebody from the Council of Aging, and Leah Lacrosse works for the town and does that, and somebody from the Fishing Alliance Services.
Fishing partnership, yes.
It's Fishing Partnership. So those three people will sort of do that sort of thing. That'll be good, I think.
Can I ask, Judy, since the since the new regulations went through, has there been a decrease in the number of variance applications for additional bedrooms and it seems we haven't had a lot lately.
Yeah, I think it seems to be, yeah, I could have to look and see what the numbers look like between this year and last year. It's relatively new, in the last, since.
You mean the change?
Since
to the rule where
January.
you-
The number of bedroom, you're
already-
not allowed to get a sixth bedroom if you already have 5 bedrooms on it.
Yeah, I mean, I
Very
would
nice.
say it has affected that, but I'd have to look at the numbers. After a year, I'll really be able to compare them, but it's only been really since like March, so. But I do get a lot of calls from engineers clarifying, oh, if someone has 5 bedrooms and they're on a 40,000 square foot lot, can I add another bedroom? And I say no.
And then the two of them know, they know now, I mean, there's.
Yeah, they're starting to
Well, I think,
understand.
yeah, it seems that
does
that there have been fewer.
Yeah,
Good.
so.
All right. Anything else, old, new business? Okay, then we have minutes from September 23rd. Does anybody have any additions or changes? If not, I can get a motion to approve.
I'll make a motion to approve.
In a second.
I'll second.
And then we can probably take a voice vote. All in favor of approving the minutes of September 23rd, say aye.
Aye.
Opposed? Okay, so those minutes pass. And I think that is probably all we have for today.
That's it.
So if I take a motion to adjourn the meeting,
I'll make a motion.
in a second,
Second?
and then all in favor of adjourning the meeting, say aye. Aye, opposed? Okay, meeting is adjourned. We will turn our mics on.